half of people across the country receive a diagnosis. It's about 48%. But there's a twofold variability from 38% to 76%. So our aspiration is to increase the diagnosis rate and close the gap. And it's a very important point about the variability of services. There are some services that are available, and I sympathise absolutely that these services are not around in terms of bespoke services, whether it's on age or physical illness. So I think it's a very good point. And one of the things that we do at NHS England, working with colleagues in social care, is to raise the profile. So it's a very good question. And I know recently there have been there's specific interest in younger people who have dementia, and that's very important.
That's great. Thank you, Alistair. I have another question here.
Hello, my name's Charlotte Peters-Rock. I'm only here today because I've been able to put my husband into respite care. He has severe dementia, vascular dementia. And there seems to be no opportunity to keep him at home when I'm not there. There is no care offered. At the moment, it seems that people with dementia are going in the opposite direction to those who formerly with learning disabilities were kept behind high walls and with locked doors. And I think we can do a lot better within the community to support people so that in early stage dementia they can still live with their friends, with their families, enjoy life, have a proper social life. The way this man is presenting it is wonderful. And I think if we put in the pooled resources of health and social care to set up proper community centres that were really welcoming to everyone who would run the centres. In the nearest town, people could go to such a centre by the day. It would improve public transport to let them get out. It would make them far more bullish about their own life, less inclined to want to be a patient, keep them away from A&E, keep them away from GPs. They'd be able to shop. They'd be able to go to the GP if they needed it, to the optician, to the dentist while they were in such a space, and it would support them totally. It's no good waiting till they're ill to support them. They're not ping-pong balls. They need to be looked after well, and I can see that you're interested in that.
Thank you. Thank you very much for that comment. And because we've got so many people who want to speak, I'm going to, with your permission, take this lady over here and this gentleman in the front before I ask the panel to respond.
Alistair immediately goes, oh no, not her. Hello, Rachel Niblock, representing the Dementia Action Alliance, the Carers Call to Action. What I would like to say is that I think it's absolutely vital that post-diagnosis education, information and support goes hand in hand with diagnosis for the person with dementia and the family that are involved in supporting that individual in the years that will follow. The call to action is very much about recognising the value, the expert by experience of the family carers in the whole process. And let's look at putting some really relatively inexpensive solutions that we can see modelled across the country in terms of giving people education, information at the point of diagnosis, which will reduce the impact of expensive crisis intervention later on.
Thank you, Rachel. And now I'm going to ask Derek to speak.
My name's Derek Whitehead, and in 1999, Alistair diagnosed my late wife with vascular dementia. She progressed with multiple strokes from then on, and by 2003 she was completely paralysed, unable to speak, as far as we could tell, unable to comprehend, and doubly incontinent. And I looked after her at home in that condition for over 5 years. A great deal has been achieved in the treatment of strokes over the last few years. And in fact, the question is not about strokes. My question is about Alzheimer's. I do not believe that there is a single silver bullet that will actually control Alzheimer's disease. But I do believe that there may be multiple small single bullets which may control various phases and aspects of Alzheimer's disease. Could Alistair comment on that?
That's great, Alistair. I think that's an invitation for you to comment that on the other things that were also said, and then I'll take Beth.
Yeah, perhaps if I could, if June and I could take them in the order. I think that's a very important point that you're making about bespoke services. It was interesting as you were describing. There were lots of people involved in that: the dentist, the local shopkeeper, everybody. And for me, it's a dementia-friendly community. And as you know, one of the initiatives is Dementia Friends, and Beth and I are wearing Dementia Friends badge. And it's getting that understanding. And one of the announcements that was made last week were encouraging big businesses to be Dementia Friends. But you're absolutely right, and Beth has mentioned it, it's that integration. And the Better Care Fund that I mentioned, diverting money from the NHS to social care to do exactly what you describe, less attendances at A&E and the like, is very important. So it's a very important point that you've made, and thanks for that. Rachel, the Carers Call to Action is a fantastic initiative, and I think everyone should have a leaflet on it. I don't know if there's enough to go around, so everyone should be able to sign up to that. And Rachel is spearheading something that is extremely important. One of the previous calls to action we had was the reduction in the use of antipsychotic drugs, and we achieved a 52% reduction in those medications. So the method of a call to action really works. So support that you can give to the Dementia Action Alliance and to Rachel for that is very important. As you know, Derek, as you mentioned, you and I go back a long way, and you're absolutely right that there won't be one thing. And the pioneering work that you were involved in and led in terms of changing stroke services, I think there's much that we can learn in terms of dementia care in that. But you're right, it's a range of approaches. We know that Alzheimer's disease isn't one disease, it's a number of different types of disease, and that personalised, some people call it personalised medicine, identifying for an individual what the best treatment would be, I think is very important. And as you mentioned, the issues of vascular dementia are important there as well. So I agree absolutely. It's getting, if you like, little bits rather than waiting for a single magic bullet.
And Alistair, before I ask Beth to comment on what's been said so far, one of the things I'd like to reflect on is the question of diagnosis, because Beth, you might want to reflect on this in your comments, Beth. For those of you who don't know me, I'm the director of the Dementia Services Development Centre at the University of Stirling, and we work all over the world. We particularly work in the 4 countries of the UK, and the dementia diagnosis level, Beth, in England is, as Alistair said, less than 50%. But in places like Northern Ireland and in Scotland, it's way higher than that, up at 65, 70%, not just in the best places, but on average. What do you think is the problem with the dementia diagnosis rate in England? Because post-diagnostic support is all very well, but it doesn't really help you if you don't know what the problem is.
I've always believed, in terms of variable diagnosis rates, that a lot of it has to do with the climate that exists around dementia in any particular locality. Now, in Scotland, you have a pioneering example of how people with dementia have been encouraged to help formulate policy. You've got a world-leading group in terms of peer support. I think that would encourage people, that would give them hope. I think if you have good services, you have good awareness of dementia, and you have GPs who understand the condition and can diagnose someone in a relatively timely fashion through a memory service, and then refer them on to a raft of other services, people are much more likely to come forward. If you're living in a locality where there's pretty much nothing, which is where we lived when my father was diagnosed, GPs understandably are thinking, well, what am I diagnosing this person into? A black hole of absolutely nothing, first of all. And then even if there are services, how good are those services? We rely heavily on the voluntary sector. So I think in Scotland you've done probably better with awareness than we've done. I think you've got a great system of peer support.
So I'm going to test you here. I'm going to test you, Beth, because you say in Scotland use. I don't really think I'm representing Scotland any more than Alistair is, because he's a Scot as well by birth. You're talking about Scotland as if one of the things that made a difference in Scotland was the Scottish Dementia Working Group, and they're great. If they were here, they'd be beating me up for not saying that they were the cause of all the improvements. I actually think the thing that made an improvement in Scotland was that the government set a target. Everybody hates government targets, but the people working in the NHS in Scotland were told that they had to improve the number of people diagnosed by 30% in 3 years. No argument. How many people here would put up their hands for a target like that in England? Now, those of you who didn't put your hand up for a target, tell us, once Beth's finished comment on this, tell us why you don't fancy a target. Because if a target gets results, what's not to love about a target?
I'm not sure that I like the idea of beating clinicians over the head to do things. I actually want to empower our society, our entire community, from young to old. I want everyone to understand about dementia, and if they experience symptoms that may be dementia, and they may also not be dementia, that they will feel empowered to come forward and they will meet with a clinician who has the knowledge and skills and services available to them to diagnose them. It's not for me ultimately to decide whether we have targets. That'll be something for Alistair and colleagues at the Department of Health and all of that. I think there are some quite ambitious ideas in terms of increasing diagnosis rates. But personally, I would prefer a whole holistic approach where we actually...
Feel your power. You know, if you think it's a good idea, they'll do it. If you don't think it's a good idea, they won't. And so the question I have
if that were true, June, I'd be running dementia policy and things would be very different.
The question I've got to ask Alistair is, if the doctors don't fancy it, you know, Beth said, you know, that she knew of doctors who thought it was a black hole and all the rest of it. Shall I go to Marks and Spencer's to get my diagnosis now?
That's a very good point, June. When you were saying, I'm not sure if there's any other way to be a Scot other than by birth, but maybe that's a conversation we have. In fact, some people say, why is a Scotsman National Clinical Director for Dementia in England? And as we know, when a Scotsman moves from Scotland to England, the average IQ of each country increases. But it wasn't me who said that. I think the issue of a target sometimes, June, is, you know, when there is a target, it's superficially exciting and people say, oh yes, and everything like that. But then you can very easily see, you know, why did you choose that particular level? And what's the reason for that? And for me, as Beth has said a lot better than me, it's not the diagnosis of a target of a certain number of percentage. It's whether we call it post-diagnostic support or peri-diagnostic support, I'm not sure. It's that package around it. And the issue of getting the diagnosis, and stories that I get from colleagues when they say, what's the point of making a diagnosis, exactly as you say, when there's nothing there. I think it's building up those things to encourage that. And that is much more powerful than having a top-down target, if you like, just for the sake of it. I'm not saying that Scotland, you know, it's one way of doing it. As you know, the health system is different in England now as it is in Scotland. But I think there's a much more nuanced way that can get the quality of the diagnosis and not just a number.
Yes, and Scotland is good, but it's not perfect. I really want some more comment from the audience
June,
now.
Before we go on, can I just very quickly address the couple of points that were made earlier? To this lady, in terms of respite and care for your husband, I think you said it was. One of the ideas that I've heard recently, which I absolutely think is a great idea, is we have lots and lots of care homes in our society, and most of them are in the middle of communities. Why can't we turn those more into community hubs? Doctors and various different healthcare professionals come into those places. Why can't we actually open them up a little bit more? Why can't we make them more of a community hub where we could actually give people services, educate carers, help them with things like moving and handling, and just really basic stuff that would help them and improve their quality of life. So that's maybe something to pursue for the future, something I'm quite keen on. And very quickly, obviously, for Rachel, I signed up for the Carers Call to Action on day one. I was actually there at the launch. So personally, I'm a huge fan of it, and obviously I would encourage everyone to go forward and join up with that. I don't know about magic bullets for Alzheimer's particularly. I'm not a medic, unlike Alistair, but my father had vascular dementia. I'm very aware of stroke and the effect that has on someone's life. And I believe once you've met one person with dementia, you've met one person with dementia. When you've met one person with vascular dementia, you've met one person with vascular dementia. Everything is unique to the person. There are no two people who experience things in the same way, and that's why I believe we have to have services that are very much about the person rather than about lumping everyone together.
Thank you, Beth. And we have two more people who have microphones, a lady near the front and someone near the back. So we'll take the lady at the front first and then the next lady. Thank you.
Thank you, June. This is Anna Gohan, Chief Exec of the Life Story Network. And really, Beth, it's in response to your suggestion around community care homes being the hub of the community. And as you'll know, as part of the PM's Challenge on the Dementia and the Dementia Compact, that was first mooted by Martin Green in terms of his ambition for care homes. Now, rightly so, and it is a very laudable ambition. We've done a piece of work with care homes as part of a DH-funded project. And for many of the current care homes, there are real issues in terms of financial resources, the high dependency levels, staff turnover, and basic resourcing of that. Now, whilst the project that we've done in terms of relationship-based care within the care home, it has improved the situation for residents and the staff within those particular care homes, there's a real issue in terms of turning that ambition into a reality. I like the idea of actually what we've now done is make sure that the community connects to the care home as opposed to the other way around. So we're doing a lot of work with housing associations and care homes and schools, brokering some relationships between them. So you actually get the community coming in to actually engage with people and actually know what really matters to the individuals in that care home. So I think it is an ambition, a very honourable ambition, but I think it remains that at the moment.
Thank you. And now the lady at the back.
Hello, I'm Trudy Nichols. I work as a community...
Trudy, I don't think we can hear you. Just try
Sorry.
a bit louder.
I'm Trudy Nichols from South Central Ambulance. I work as a community health practitioner. I'm only too aware of the undiagnosed patients with dementia in the community. I wondered how soon it's likely to be that we are able to have a direct referral service to the dementia team like we do with other aspects of patient health such as strokes and falls and community nursing.
What a fantastic question. So I think that one is for Alistair, and the other question, if you lead on the other question for us, please. Beth?
Okay, so in terms of, first of all, Life Story Network, I absolutely love the whole idea of life stories. Actually, in the project I'm doing with McIntyre at the moment, we're very much looking at creating life stories for everybody who's involved in receiving care from them. The idea, absolutely, as you say, is very much Martin Green's baby, something he's talked through with me at length. There are obviously going to be a lot of stumbling blocks. You're going to have health and safety concerns. You're going to have security concerns. There's going to be a whole raft of reasons why it wouldn't work. Maybe ultimately it never will happen. But I think it's something that's definitely worth further exploration. Obviously, it would need more partnership working between the public and private sector, which, as we all know, doesn't happen routinely. So it's a bit of a slow burn, but I do agree with you, Anna. It's got potential, and in terms of what you guys do, I absolutely love it.
Thank you. And Alistair, direct referral via the paramedics and the ambulance service?
Yeah, to be honest, I don't see a problem with that. And one of the issues is trying to work things out at a local level. And I bet if you got a group of people around involved in dementia care in that area, and I've seen it in a number of places, and worked out what it might look like on the ground in terms of not being frustrated by a system of having, well, a load of nonsense that is, to have to go through a system and get permission from people, something locally that you can do that directly. So someone who has a diagnosis of dementia and is being supported, that if you as an ambulance crew are called, that you have support from that. I can't see any reason why that using a local protocol would not be allowed. One of the things that I've learned in the last 4 years doing this job, it's easier to get forgiveness than permission. So if I was going to go and do something, I would just knock a few heads together at a local level, happy to help if I can, and make it work, because that's the kind of thing that could improve care for people with dementia.
That's great. I've got another question here.
Thank you. Chris Wood from Action on Hearing Loss. I was just going to ask, it's come up a few times already the discussion around creating more personalised care and fitting the care around the person. We know that people are increasingly having more than one long-term condition. and they're not always having their needs met, especially when they're a vulnerable group like people with dementia. And at Action on Hearing Loss, we know that specifically people are at least twice as likely to go on to develop dementia if they have hearing loss to begin with. But perhaps even more shockingly, we get a lot of cases of GPs who find patients who not only haven't been diagnosed with their hearing loss because they've got their dementia, but have been misdiagnosed with dementia when they actually only have hearing loss. So how do we break down the specialisms? How do we overcome the barriers within the NHS to make it more person-centred and deal with all those multiple conditions?
That's great. So that's a question on hearing loss. And because we're so close to the end, I wonder if there's one more question we can take before we ask for the final comments. With respect to anybody who hasn't asked a question yet?
Is there a clinical way of diagnosing dementia, or is it purely on a behavioural diagnosis?
So that's one proper doctorish question, which is good. And then the question about the difficulty of people who've got multiple impairments and dementia. And just because I'll give the final words to our colleagues here, I want to just say something on my own behalf at the moment, which is sometimes I worry about the extent to which people are giving diagnoses of dementia and the extent to which people are being given jobs where they're looking after and supporting people with dementia without themselves having much dementia knowledge or education. So I'll hand over to the team on the sofas. So
taking up on Chris's point about multiple long-term conditions, it's absolutely true that dementia very rarely exists in isolation. Obviously, dementia is predominantly associated with people as they grow older, and obviously as people's age, they are likely to develop other long-term conditions. I'll tell you a little quick anecdotal story, and it will have to be quick because June will beat me over the head otherwise.
I'm very strict.
In one of my dad's care homes, there was a lady who was almost completely deaf. She was almost completely blind, and she had dementia. And eventually she needed help with eating and drinking because she was developing dysphagia. And she couldn't see what she was being given. She couldn't hear the instructions that food was coming, and she dramatically started to lose weight, and it did actually result in her death. So I think in terms of actually being aware, particularly of sensory impairments, which obviously in your job is something that's vitally important, I think it's something we really do need to actually consider and give people proper care and treatment for, because if you have dementia anyway, it's going to make your life 10 times more difficult. And if you don't, then, as you say, it could contribute to a deterioration in later life. So incredibly important that we look at those.
Thank you.
We know dementia rarely travels alone, so 80% of people have another long-term condition, and perhaps one of the issues is to think of dementia in some way as a long-term condition and look after those comorbidities. A very good point about sensory impairment, and there's a lot of interest and work about hearing loss and visual loss in dementia, so it's an extremely important point. I think I got the question about the clinical diagnosis. Dementia is a clinical diagnosis, and so things like a brain scan and blood tests and everything are largely to exclude other things, but dementia remains a clinical diagnosis. I think if that was the question you asked, then that's it. But that is part of the interest in dementia. It goes back to if you like, a traditional clinical approach.
And one thing just to say as a footnote is, sometimes when people are talking about dementia, questions arise in the audience that it's too hard to ask in front of other people, or perhaps you didn't get the chance to ask the question you really wanted to ask. So if you Google June Andrews and Dementia Centre, then you'll be able to email me and ask me any questions. I think everybody knows where they can find Alistair Burns, who's the dementia czar. That's what it says on my phone when he pages me. It's the dementia czar. He's in charge of dementia. I suppose if he's the czar in England, that makes me the sultana in Scotland. And
it sounds reasonable to me.
Sounds reasonable. And that's the best of his jokes. You should have heard the ones I told him he's not allowed to tell. And also, for people who haven't seen it yet, find Beth Britton's short film that she made for the G8 summit, which describes clearly what life is like for a carer and expresses clearly what things we have to do. There are so many issues that we didn't cover in this discussion. I want to know, bearing in mind how many people with dementia there are in hospital wards, why hospital care is still so poor in so many places. I want to know why it is that GPs are still managing to believe that there is no point in making a diagnosis, timely or not. So there are lots of questions still to be asked. But a really important thing from both of our speakers today is to understand that there is a lot that's being done, there's a lot that's still to be done, and we must be enthusiastic and we must be determined that we're going to make a difference, because nearly everybody in this audience is affected by it. So thank you very much for coming to our presentation, and enjoy the rest of the conference. Thank you.
Hi everybody, good afternoon. Welcome to our next session. Our next session is all about research and innovation for future challenges. And to deliver this speech, we have the chair of NHS England, Sir Professor Malcolm Grant. And Sir Grant is going to be talking really about what the challenges are that lay ahead for us in the NHS, and also how we can better judge how to deal with these issues and innovate around them. So without further ado, will you please put your hands together for Professor Sir Malcolm Grant.
Thank you. Well, thank you very much, June, and welcome everybody back after lunch. I want to talk with passion about research and innovation in the NHS. I'm going to outline what seem to me to be some of the key opportunities that lie in front of us, and what is unique about the position of the NHS in 2014. I want to talk about the challenges, those 6 characteristics of a sustainable healthcare system in 5 years' time, and what is the role of research and innovation in driving them forward. I want to talk about 2 prime examples of what we can do in this country in research and innovation to advance the interests of patients. But if you want evidence of the appetite for research and innovation in healthcare in England, look around you. Expo 2014 has brought together an extraordinary array of stalls, of presentations, of innovation and of ideas. And the way in which we can build on that for the NHS, I think, is to take advantage of what we have uniquely in this country. The first is a model of socialized medicine with unique, almost universal coverage, free at the point of need, and providing a wealth of information and of data. I won't repeat the discussion that occurred this morning around our care.data initiative, but without those data, we're flying blind. With those data, intelligently applied and analysed and used, we have a fantastic capacity to provide enhanced healthcare for the future generations. The second part, the second leg of this stool, is quite simply the presence in this country of absolutely world-class universities, complemented by the research charities, the Wellcome, Cancer Research UK, the British Heart Foundation. We have an extraordinary amalgam of powerful, dedicated, committed interests to the cause of research. We can see them manifested not only in the universities themselves, but also in those great institutions. The Laboratory of Molecular Biology at Cambridge, more Nobel Prizes than most countries in the world have. We've got the Sanger Institute just outside Cambridge, which was one of the pioneers in sequencing the human genome. We've got a rising, immediately adjacent to St Pancras International Station, the new Crick Institute, named for Francis Crick, who, along with James Watson, was the discoverer of the dual helical structure of DNA. So we have a huge intellectual resource. And then the third leg of the stool is British industry. By that, I don't mean solely the pharmaceutical industry, which still has a significant presence in this country, but I mean the whole array of life sciences industry and the whole array of manufacturing industry, of the IT industries, that intellectual capital operating in the UK, who, if it can be brought more successfully together with the NHS and with our universities, can start to found a new developed approach to research and innovation that's unique. No other country can do this, with one possible exception. Let me give you a figure which demonstrates, to my mind, some of the distance that we have to travel. I owe this to Nico Henke from McKinsey, who tells me that in Sweden, the annual budget for a socialized model of healthcare is around 32 billion euros. The earnings that Sweden has from the exports generated by its healthcare industries is in the region of 27 billion euros, a remarkable balance of innovation for the people of the nation and the creation of jobs in the wider economy. That is the golden aim for innovation and research in a modern healthcare system. We then, I think, have to try to put that into a context of reminding ourselves what it is that we have achieved in this country in terms of research and innovation over the past 3 decades. I'm just going to identify 5 world firsts. Let's start with the world's first test tube baby, Louise Brown, born in 1978 at Oldham Hospital as a consequence of the work using in vitro fertilization. She was the pioneer, and it is a technique that has spread from this country across the world. From a point at which it was a hugely ethically controversial intervention to create human life in a test tube, to a position where it is now available on request within the NHS. Secondly, to the world's first paediatric triple organ transplant at Birmingham's Children's Hospital in 1998. Thirdly, the world's first heart valve grown from stem cells at Imperial College in 2007. And I would add to that the remarkable feat just 3 years ago at Great Ormond Street Hospital of developing a trachea built around a nano-structured scaffold using the stem cells from the patient, who was an 8-year-old child born with a restricted airway and into whom was successfully transplanted a wholly new organ capable of growing with the child. Extraordinary, extraordinary breakthroughs of British science for the benefit of patients. And then we have gene therapy, which has been used in Great Ormond Street. It has been used at Oxford University, being used at Moorfields Hospital to overcome hereditary blindness conditions. We have the extraordinary achievements in surgery, the world's first automated liver transplant carried out at King's College Hospital, the first heart surgery using a fully remote-controlled robotic arm, and the first keyhole surgery operation using 3D cameras. Extraordinary breakthroughs in this country. What I do believe passionately in is the need to ensure that with these we move not only from, as we have done, from bench to bedside. That trachea operation probably cost us about £1 million. But from bedside to bedsides, finding the secrets of replication, of rolling out discovery for the benefit not just of one patient, but of patients more generally. And secondly, to ensure that the economic activity that we can generate is not transported and is not exported in jobs to other countries, but remains as a focus for investment in this country, developing not only improvements in treatments and in healthcare for our population, but also earning vital dollars for our economy and creating jobs in the broader economy in England. That is our frustration, how to turn this extraordinary wealth of energy and of intellectual power and leadership into something that is not simply a series of disconnected one-offs, but becomes a powerful driver of change across the NHS. When the 2012 legislation was taken through Parliament, great care was taken to insert into it a statutory duty on us at NHS England to promote research for the benefit of healthcare in England. But secondly, to ensure that the evidence generated from that research is used in the promotion of high-quality healthcare in England. It's a duty that affects not only us, but also all the CCGs, the clinical commissioning groups. It's something where I hope we have ignited a whole new fuse which will spread across the entire system of enthusiasm around research, of the engagement of patients in research. Let me just say that in England, we have a higher proportion of patients engaged in cancer research trials than any other country in the world. We're not laggardly when it comes to research. In fact, we're global leaders, as I've demonstrated. But now the challenge is coming in our direction. Within the brochure, which contains the program for these 2 days, there is a summary of the 6 characteristics of a sustainable healthcare system that we believe are going to need to be pursued over the coming 5 years. By the way, this is not a blueprint. It's not a global strategy. It's not a top-down definition of what the future needs. This is a reflection of the new culture in NHS England, of the culture of enabling, facilitating, encouraging, but allowing local initiative to prevail. Those 6 characteristics are deliverable only with innovation, only with a drive towards doing things differently and improving outcomes for patients. The very first of them is all about patients. How we can put the notion of an empowered patient at the heart of everything that we do. And those of you who have heard any of the presentations involving patients here today or yesterday or at other events will understand how powerful that is and what a driver for change it truly is. That is the patient. It's not the managers, it's not the providers, but the patients who lie at the heart of everything that we do. But look at the implications for innovation around the empowered patient. The implications for providing technology that can support the notion of a patient for the future. The patients of today are not going to be the patients of tomorrow. Our children, and in my case, our grandchildren, are going to have very different approaches to their relationship to providers of healthcare. Why do we use the word patient? Why do we have waiting rooms? What is it about this relationship between the patient and the professional? And how long will that continue into the 21st century? Or let me ask a more fundamental question which has been posed by those who have been reforming parts of healthcare in New Zealand following the earthquake in Christchurch, which took out a large number of hospital beds. Their first question is, why do hospitals need beds? What is it that we can do about providing a more integrated model of healthcare for patients that does not require the provision of a traditional hospital environment? The second of our 6 characteristics is around general practice on a wider basis and provided at scale. This is a process which is, of course, already occurring. The coming together of GPs through alliances, through federations, and through cooperatives to ensure that what is being provided for patients takes across a broader intellectual swathe of activity in terms of diagnostics and therapeutics, but also allowing us to think forward into bringing more and more general practice into the public health and into the prevention arena. We have to have the data. We have to have the technology, we have to have the research and the innovation that allows all of that to flourish. And then thirdly, the model of a more modern model of integrated healthcare. It's trite to talk to this audience about the proportion of population suffering from long-term conditions. with an aging population and a healthily aging population, we nonetheless have a rising incidence of those with one long-term condition, something like 15 million patients in the country. Those with two or more complex long-term conditions, rising up to, we think, about 3 million patients within the next 4 years, and consuming something like 70% of the health budget. How do we provide a system of care that's crafted around the needs of the patient and no longer focused so strongly on hospital care, but bringing care out of the hospital and crafting it around the patient? Again, we need innovative models. David Nicholson spoke, I thought, very movingly this morning about diabetes and about the management of diabetes. No longer so much in a hospital setting, although there are circumstances where that's essential, but putting patients much more in power of their treatment and equipping them with the innovation and the discovery that will help to make that possible. The fourth of our 6 characteristics relates to urgent and emergency care, around which Bruce Keogh has produced an excellent report, but which we can anticipate will see a diminution in the number of A&E departments with full backup to perhaps 40 or 70 across the country, and a greater concentration on specialization of those services. And then we have, I think, a wholly transformative approach to elective care, which is to say, a step change in productivity and a step change in quality of outcomes. Where does research and innovation fit into that? I would say that the time in which the rest of the world looked to the NHS for knowledge and for innovation and for discovery is with us still, but actually the process is increasingly being reversed. We know that we can learn an enormous amount from India, from the US, from Canada, and from nations less economically developed perhaps than we are, where there is going to be a leap across cultures and technologies into wholly new ways of doing things. If in India it is possible to undertake cataract surgery with a price base 1/6 the cost of the UK and with outcomes higher, then there's an enormous amount of learning that we in this country still have to make. Perhaps it's less the learning, perhaps it's more to do with the cultures. And then finally, specialised commissioning. At the moment, we spend £12.5 billion a year on highly specialised services provided by up to 300 different providers. We know, because the evidence is there to demonstrate it, that there is a strong correlation between the volume of activity that's going through any unit and the outcomes from that unit. It's been demonstrated, again, on the basis of evidence in London, that in the treatment of hyperacute stroke, concentrating services from 30 hospitals to 8 has transformed outcomes. It's possible, on the basis of evidence, to start to enumerate the number of lives that have been saved by transforming not the treatment of hyperacute stroke, but the circumstances and the environment in which it's treated. We therefore anticipate that a sustainable model towards providing specialized services will see them concentrated in a much smaller number of globally outstanding excellent centres. Our ambition for this has to be that outcomes for patients are transformed to be always amongst the best in the world. Now, there's nothing in any of this which suggests that all of the remedies for the NHS lie in research which looks like a long-term, clinical, rather cold process. Nobody who sat here this morning and listened to Kate Granger could believe that research is somehow the saviour of the NHS. Compassion has to always be part of what we offer our patients. And yet research and innovation which drives the quality of experience, which on the basis of evidence allows us to ensure that our investments are going in the right direction, is absolutely fundamental to that future. Let me give you then 2 examples of what we're trying to do now, which will, we believe, bring about further transformation. The first is in relation to genomic medicine. This country, along with the US in 2001, was the leader in first sequencing the whole human genome. It was I'd like to say a transatlantic collaborative effort. It was actually a transatlantic competitive effort. But the two nations in 2001 sequenced the first whole genome. At that time, we were able to identify around 100 single gene-related disorders. In the years that have followed, that number has gone up to 3,000 single gene-related disorders. We now know through genetic sequencing that the incidence and the relationship between genetic mutation and various types of illness is quite profound and quite marked, most notably in the case of cancer. We know that it's not purely a genetic mutation. We know that genetic mutations combine also with environmental with environmental conditions and with lifestyle. But nonetheless, it's possible for us now to release some of the potential power of genomic medicine to understand much more about diagnostics. We know that we can, through prenatal screening using DNA, avoid 98% of what is currently invasive diagnostics for fetuses. We can use it for therapeutics. Already it's been possible to match some gene therapy discoveries against understanding of genetic mutations in patients. The consequences for us are profound, but only if as a nation we are able to grapple with them and grasp them and use them to the advantage of patients. That is why NHS England is playing a major role with the government in the Prime Minister's 100,000 genome sequencing programme. Let me just put in the state of play today. The first sequencing of a whole genome in 2001 took 15 years and $1 billion or more of investment. We can today do it for about £5,000, and we can do it in about 5 hours. We know that both of those figures will continue to fall rapidly. It's conceivable today that in the next 5 years, the sequencing of a whole genome will cost nothing more than $100, that it will be available on demand because it will be a global operation, that it has the capacity to transform the way in which we treat common diseases. But it only works if we have a capacity for interpretation of the data. Genetic data in itself is unintelligible to practically everybody and has very little value in terms of diagnostics and therapeutics. What's critical about it is to combine it with phenotypical data about the patient and also clinical data about the patient's condition. If we can do that, then we start to build up a database which allows us to understand correlations between genetic mutation and the incidence of disease. More than that, to move from the understanding of the genetic profile of patients to a new model of stratified medicine, to understand that for some patients, certain types of pharmaceuticals are likely to be effective when they're not likely to be effective for other patients. And so the 100,000 genome program, which Sue Hill, I hope, will talk a little more about in the next session, will be one in which there is leadership led at the moment by a new company called Genomics England Limited, a company in the public interest, which will assemble the data, which will work with us in NHS England to bring it all together and to enhance the experience of patients and to drive forward in a way in which this country still has the unique lead, a new model of genomic medicine. The candidates in the first instance will be around rare and inherited diseases, infectious diseases, and cancers, particularly starting with lung cancer. 100,000 genomes is not 100,000 patients because it's necessary in many cases to sequence the tumor and to perhaps sequence the DNA of parents and close relatives to understand the genetic lines. That is a revolution in healthcare for which this country is better prepared than any other. The second is the creation of the new academic health science networks. There are 15 of them. Their stalls are here, and I do encourage everybody to go and talk to them. To me, AHSNs are not just another network. They're not just another talking shop. They're not just another group of people getting together and talking about research and innovation. My frustration with this is how we break down the barriers. NHS is a fantastic area for innovation. It occurs right across. It occurs in all our hospitals. I've just been talking to somebody who has designed a device which helps to combat ventilator-associated pneumonia in King's Lynn Hospital. It's an extraordinary device. And what I have asked him is, how many other hospitals are yet using it? And the answer is 5. Now, what we need to be able to do is to take that, June, and ensure that we can replicate it across the system. I'll say no more for the AHSNs. They can say it for themselves, but a unique combination of NHS, universities, and industry across 15 different regions, doing different things and doing them in innovative ways. Thank you so much.
Professor Sir Malcolm Grant, thank you so much. Thank you. So we're going to take a quick 5-10 minute break, and then we will begin the next session. So thank you very much.
Don't think about all those things you feel. Just be glad to be here. Don't think about all those things you feel. Just be glad to be here. Don't think about all those things you feel. Just be glad to be here.
Good afternoon, everybody, and welcome to our next session. I'd like to introduce Sarah, who's signing, the lovely Sarah who'll be signing for this session. The next topic we're going to be discussing is an area that I find fascinating, the area of genetics and how our genetics affect our health and what science can do in terms of diagnosing illness but also preventing illness. So the session is called Diagnostics and Genetics to Improve Healthcare. We've got two of the leading professionals in this area, and I'm very excited because they both happen to be women, which is even more fabulous. So will you please put your hands together for Professor Sue Hill, who is the Chief Scientific Officer for NHS England, and Dr. Sian Ellard, who's a Professor of Human Molecular Genetics at the University of Exeter's Medical School. Both Professor Hill and Dr. Ellard will speak for 8 minutes each, and then we will open it up to the floor for Q&A. So, Professor Hill, will you please make your way to the lectern? Over to you.
Thank you very much, June, for that introduction. Good afternoon, ladies and gentlemen. I'm delighted to be here to give this presentation this afternoon. We'll hopefully get a slide in a minute. I'll just go back. By way of introduction, the NHS performs approximately 1 billion diagnostic tests every year across the diagnostic modalities of imaging, pathology, genetics, physiology, and endoscopy. Most of these diagnostic tests are provided from a secondary care location with very limited provision directly in primary care. As part of our future focus, we need to ensure that we embrace what future technological changes will bring, both in terms of the complexity of diagnostic testing, for example, multimodality imaging, as well as the potential that handheld and digital solutions bring from the developments in bio-nanotechnology. This will enable us to, for example, manage long-term conditions better through these mobile devices, and in the future we'll see a number of mobile molecular diagnostic testing platforms. We also need a focus on tackling the unwarranted variation as recently outlined in the Atlas of Variation for Diagnostic Services, that showed even though there was strong clinical evidence, there was a wide difference in terms of access to those diagnostic tests across England. Of course, diagnostics are crucial to enablers of improving outcomes across all domains of the NHS outcomes framework, and especially in reducing premature mortality through diagnosing earlier and intervening earlier. Our future focus as well has to be as well on integrating these diagnostic modalities to ensure that we can deliver personalised medicine for individuals. Part of our challenge for the future will be to ensure that we have a different provider landscape, so that we use the new commissioning models and financial incentives we have to both ensure that we have diagnostics within secondary and tertiary care sectors to investigate more complex disease, and also to support 7-day services and emergency and urgent care, but also look at how we can provide more diagnostics out in the community with a primary and community care focus across those diagnostic disciplines, where we can also support patients who may be using diagnostics at home to manage their long-term condition, or indeed other high street providers of diagnostics like pharmacies deliver those services safely and effectively. And into these more locally focused diagnostic hubs could be telemonitoring of individuals. Now, you've already heard from Sir Malcolm Grant that the real game changer in healthcare will be the diagnostic revolution associated with functional genomics. This will transform medicine. Functional genomics is a structured analysis of the relationship between our genes, between the genotype, and the ways those genes are expressed in an individual, the phenotype. What we can do using a greater understanding of all of our genes, or parts on a specific number of those genes, as well as how they're expressed, is really allow more accurate diagnosis of disease and the development of more effective and targeted treatment. And what we have in the functional genomics pathway is our genes actually set out the potential for either developing disease or the potential susceptibility to disease. At the DNA level within the genes, we need to get the message out to the body of how that gene needs to be translated. And that's through messenger RNA here, which sets out the implementation strategy of that gene within the body. The next step in this process is the expression of the proteins in terms of cells, tissues, structures, enzymes. And the final part of this pathway is in the production of products like metabolites such as cholesterol or blood glucose. What this functional genomics pathway will ensure that we do is both use genetics at this end and also other types of diagnostics at this end for both monitoring the disease and the response to treatment. So there will need to be an integration both across the diagnostic disciplines and with clinical specialties. This is just an example of a functional genomic pathway in action. Alpha-1 antitrypsin is a protective lung protein. Deficiency of this protein is associated with early onset of lung disease, and particularly of emphysema. If we look at the population shown here, we see a range of different variants of the gene encoding for alpha-1 antitrypsin deficiency, and that's associated with a range in the levels of the circulating protein, alpha-1 antitrypsin. In those with a genotype ZZ, there's virtually no alpha-1 antitrypsin, so none of this protective protein. But what I want to get across to you today is that these ZZ patients, so within this genotype, how that is expressed in an individual is very different. And so the patient population is not homogeneous. In 2/3 of the patients, the lung disease is in the lower lobes. In 1/3 of the patients, the disease is in the upper lobes. What this means when we look in more detailed testing is those that have the upper lobe disease, they're able to move air in and out of their lungs better than those who have the lower lobe disease. So this is showing that imaging tells us where the site is, functional testing tells us what it really means in terms of patients. But this phenotypic difference means that we need to use different treatments for this different patient population, all within the same genome. Just to finish then, you've already heard for Sir Malcolm Grant the importance of the Prime Minister announced 100,000 Genomes project. In 2000, the US, spending $2 billion, published the first draft human genome. Through the 100,000 genome, 100,000 whole genomes will be sequenced, focused on rare diseases and cancers. Alongside that, Public Health England will also be sequencing the pathogens of common infectious diseases like tuberculosis. NHS England will play a key role across this pipeline from sample collection through to clinical utility and to delivering effective treatments. And that will be through both the establishment of more genomic-focused clinical services and molecular diagnostic services. Over here, Malcolm's already highlighted the important role that NHS England will play alongside universities, industry, and also the charitable sector in establishing the research and evidence base. And all of this will be underpinned through a structured approach to education and training through developments within Health Education England. I'm going to hand over now to Sian Ellard, who's going to tell you about what this functional genomics pathway really means for patients and the impact. Thank you.
Thank you very much, Sue. But I'd like to start by introducing you to Ewell. Now, he was diagnosed with diabetes when he was just 5 weeks of age. He was put straight onto insulin, and his parents were told that he would need insulin for the whole of his lifetime. And in this video, you can see at the age of 18 months, he's not pulling himself up, he's not standing, he's not walking, and he also has this motor developmental delay. Now, my research group in 2004 found that mutations in the KCNJ11 gene are the most common cause of neonatal diabetes. And when we sequenced Ewell's KCNJ11 gene, we found this change. And this affects just one letter of the 3,000 million that make up our genetic code. And this V59M mutation is the reason that Ewell has diabetes and also the reason for his developmental delay. Now, this is a diagram that shows you how insulin is secreted from the pancreas. And the KCNJ11 gene encodes a protein called KR6.2. And this forms the subunits that comprise the potassium channel that's the key linkage between your pancreas sensing that you've just had a meal and your glucose level in your blood is higher, and then releasing insulin. And what the mutation did for Ewell was it meant that the channel couldn't close, which meant no insulin was actually released from his pancreas. And in understanding the reason why he had diabetes, this gave us the opportunity for a different treatment. Because for many years, a type of tablet called sulfonylureas had been used to treat type 2 diabetes. And we knew that the way in which these tablets work is that they bind to the SUR1 regulatory unit of this potassium channel, and they make the channel close and secrete insulin, regardless of these upstream pathways. So we tried sulfonylureas, and Ewell was one of the first patients who was able to stop insulin and control his diabetes with sulfonylurea tablets. And this is a video taken by his parents just 1 month after he changed treatment from insulin to sulfonylureas. And here you can see that he's now able to pull himself up to stand in. He's taken his early steps, and he's now joining in playing football with his brother. So dramatic improvement in his motor skills. We saw this in other patients, and other benefits included better speech, improved concentration, and better sleep patterns after transfer to these tablets. Now, neonatal diabetes is a very rare condition, and in the UK, there's not even 200 patients who have this rare form of diabetes. And there's a very clear clinical message, which is just that any patient who develops diabetes in the first 6 months of life should have a genetic test. And that genetic test will define the best treatment for that patient. But there's another form of monogenic diabetes caused by a mutation in a single gene that affects an estimated 30,000 people in the UK. And this is called MODY, maturity onset diabetes of the young. And at this point, I'd like to introduce you to Dan. Now, Dan comes from a family where there are actually 14 other people with diabetes. So there should have been a clue there that there was something genetic. But when he was diagnosed with diabetes at the age of 16, it was assumed that he had type 1 diabetes, and he was put straight onto insulin injections. And he was given himself 4 injections every day. Now, he'd just started in sixth form college. His family are farmers, and he was keen to become a vet. But he was really struggling because he was having severe hypoglycemic episodes, missing a lot of school, and was struggling to achieve the high grades that he would need to get into veterinary college. But we did a genetic test for Dan and found this mutation in the HNF1 alpha gene. Now, HNF1 alpha mutations cause this MODY type of diabetes, which is typically diagnosed in adolescence or in early adulthood. But most of these patients are assumed to have type 1 or type 2 because MODY is rare. It accounts for just perhaps 2% of diabetes. But we know that this will also respond to sulfonylurea treatment because these tablets will bypass the metabolic defect due to the HNF1 alpha mutation. Now, Dan came off insulin in 2005, and this is a quote from Dan. He talks about the big day in May 2005 when he stopped insulin, tested his blood many times, and then he says how different it's been. I was looking to fail college and then to get A's and into vet school. It's fantastic. And I'm really pleased to tell you that Dan is now a qualified vet and has very well-controlled diabetes. And his mum told us what a huge relief it was to get an exact diagnosis and the appropriate treatment for Dan. The change for Dan is immense. Now, we started offering diagnostic genetic testing in my lab for the whole of the UK in 2000 for MODY. And we estimate there are 30,000 people affected, but we found less than 5% of those people. And if you look at the number of confirmed cases across the UK, you see a wide variation, with greatest awareness in the southwest of England. And there are many reasons for this, but we think the biggest reason is lack of awareness about MODY. So people don't know it exists, they don't know the treatment changes that come with a diagnosis, and they don't know which patients should be tested. So to address this knowledge gap, we've trained a national network of genetic diabetes nurses. Now, these are diabetes specialist nurses who come to Exeter. They're seconded for just half a day a week, and they learn about monogenic diabetes from our multidisciplinary team. They then go back to their local regions and they give talks to people who look after patients with diabetes. They liaise with colleagues and try to identify the right patients for genetic testing. And when they find a mutation in a patient in their clinic, they will then organise testing for the relatives who may live elsewhere in the UK. And one of the most important things they do is they support patients who are stopping insulin, because most of these patients will have been diagnosed as having type 1 diabetes and told that without their insulin, they'll die. So this really is a big deal for patients, and they do need to be supported through the process. And I'd like to leave you with some words from patients. If I can move the slide. Thank you very much. So we have Mary and Margaret, who have HNF1 alpha MODY. And Mary describes her genetic test as the best blood test I ever had. Margaret says that even though I take these tablets, I don't feel like a diabetic anymore. And Sophie has neonatal diabetes and told us it's changed my life completely. Thank you very much for your attention.
Fantastic. Thank you very much. I find this area absolutely fascinating. So I'll start with you first, Sue. So what does the 100,000 Genome Project mean for the industry in general. It's a real game changer, but how so?
Because for the very first time, so as I mentioned, in 2000 in the US, they sequenced the first draft human genome for about £2 billion. Now that can be sequenced for less than £1,000, coming down all the time. What this means is, instead of in the NHS currently looking at a single gene or a small number of genes, we can look at all the genes, like the whole of the telephone book of genes for all of us sitting in this room. So that's a game changer in terms of our understanding of disease and the susceptibility. For industry, in terms of the ability that industry may have to provide the whole genome sequencing platform, that means that it stimulates that industrial market in terms of providing those for the NHS at a low cost. So it becomes an accessible test and something that's part of routine sort of clinical practice. There's also, I think, as we've highlighted from myself and from Malcolm, the real importance of the research and innovation part of this, because at the moment, we don't know what that's going to look like. We can only assume. And the bit that's really important is the rest of that functional genome about the proteomics, the protein expression, and the metabolites, and that part of the development of biomarkers that can be used in everyday clinical practice. So there's a second order of benefit for industry around the development of biomarkers and their commercialization.
It's a fascinating area. And so, Sian, do you think we'll get to the stage where you can actually diagnose disease or the potential of disease at the fetal stage and be able to correct it at that stage? Does this science allow for that?
Indeed, and a fetal genome has already been sequenced by several groups across the world. And certainly one of our research projects is actually developing this technology to predict whether a baby has inherited one of these monogenic diabetes mutations. That's not actually for the purpose of predicting whether they'll have diabetes, but because some of these mutations affect the size of a baby and thus the potential for problems during delivery. So it's actually a test to predict the baby's size and obstetric management, but it just shows the broad range of applications that are possible.
Fascinating. And how quickly do you think GPs will have diagnostics? Sue?
Well, already there
or
are...
what would you want the pace to be at?
I think already there are portable molecular testing platforms for particular genes. And I was recently at Loughborough University where they're developing, this is in their Department of Sport and Exercise Medicine, developing almost plaster type technologies to use in athletes to monitor some genetic expression and also biomarkers. So you could see that the technology is moving at pace. So we're very close to having the portable diagnostic testing available at a multiplicity of locations across the healthcare system.
Yeah. Well,
but for not for the whole genome, for very specific genetic genes, or, for example, to detect infectious disease.
And so for you, Sian, as somebody that's at the forefront of this area of study, where do you see it going 5-10 years from now? What will we be able to do?
I mean, I think in the area of diabetes, we would hope that as soon as a person is diagnosed with diabetes, we'll be able to do a genetic test, predict whether it's a genetic subtype, predict the clinical course and the best treatment. But there are so many genetic disorders for which patients currently do not have a diagnosis.
Yeah.
And that technology really provides a huge tool in our armoury. And I hope for many patients that this will be the means by which they finally get that diagnostic test and then the development of new treatments.
Will it be at a stage where it's simple enough for everyday folk to be able to understand? Because at the moment, if it's a sheet of paper with your whole sort of genetic sequence on, only professionals like yourself understand it. Will we get to that place where we can
I think it's how you present it. I mean, I think everybody in the audience and everybody's children could look at that electrophoregram and say, that's the difference.
Yeah, that's the bit that's
Yes.
off. Yeah.
And I think for us, some of those changes that we see, we can say, yes, that definitely will cause this disease. For others, there's a lot of uncertainty.
Yeah.
But the new information we find from sequencing the genome of 100,000 people will help with that grey area, help us to interpret.
It's very
those changes
exciting,
we
isn't
see.
it?
Let's no doubt about it. Part of the response on the NHS side to the 100,000 genomes will be having more specialists who understand the enormous amount of genetic information that will be generated, and then understand from that, if you drill down very specifically, what the clinically significant findings are. And that's why with the health education programme that I'm really actively involved in leading, that we're starting the work to raise awareness across the whole healthcare workforce, because the general public can now look at the internet and get a lot of this information already, and some are even paying to have their whole genome sequenced already.
23andMe and all of these companies.
So we just have to ensure that both our workforce can respond and they can respond to the questions that patients and the general public will have in this area.
Yeah. So will it also mean, obviously you're able to sort of diagnose in a much more sort of bespoke fashion, as it were, but presumably it will also mean in terms of how you medicate, because at the moment if you have cancer or whatever, it's a standard procedure in terms of how you deal with it, in terms of the amount of chemotherapy you prescribe or whatever. But presumably you'll be able to drill down and know that this particular person needs this amount. And do you understand what I mean?
Exactly, yes. So chronic myeloid leukemia is a very good example where we have imatinib treatment, which is effective. More than 95% of patients will go into remission. But very often a resistant mutation will develop. And we can actually determine that particular mutation, and then you go to your list of drugs that have been shown to be responsive in those patients with those mutations, and that's your next line.
And know exactly
drug.
how much that particular patient requires.
And then there are other variants in your genome that would predict the levels of enzyme you have that metabolize specific categories of drugs. And therefore you can say, well, this patient has this genetic makeup. We should make sure that the prescribing level for this drug is X. Be much more precise.
But that's why certainly the ongoing work in functional genomics, as well as the 100,000 genomes, will also enable the pharmaceutical companies to develop more targeted treatment as we understand it more. And we have currently a whole different forms of targeted treatment for different forms of cancer. That we need to ensure that patients receive, because they have better outcomes from those treatments, as Sian shown very elegantly with the young people with diabetes.
And on a sort of a slightly random note, presumably people will then start using it in their mate selection rather than even whether you're attracted to someone. Like, oh, can I see your genome sequencing, actually?
Well, we laugh about that, but we're all carriers of about 20 recessive disorders. And rather than experience the situation, have a child with one of those disorders.
It's true. Well, there you go. Do we have any questions? Lady at the front. Rebecca? Just here, if you go to this lady here.
Thank you. Yeah, absolutely fascinating. I'm going to sound a little bit sort of cynical here, because I'm not, but I can be concerned very much with the ethics and governance around the sequencing, and I think that's something that you've got to really make sure you've sorted out and you've got robust before you go any further. So could you say perhaps something about that?
So as part of the 100,000 Genomes project, and although I didn't talk about this because of time, there is a piece of work that's really looking at ethics and governance of the whole process. And that will build upon the work that's already been done in this area previously. And I think your point's very well made and is already recognised as something that's got to be addressed.
Brilliant. Well, thank you both so much. This has been fascinating. Can we have a round of applause, please, for Sue and Sian? Yeah? We're going to have a quick 5-10 minute break, and then we will be back with our next session, which is called Enabling Hospital Patients of the Future. So we will see you shortly. Again by the lovely Dion, who's going to be signing. You right, Dion? Yes, thank you. Good. No, you're supposed to sign that. Okay, so our next session is titled Enabling Hospital Patients of the Future. And we're very excited. Our speaker has flown in specially from the States to deliver this talk. Will you please put your hands together for David J. Cook, MD, Professor of Anesthesiology at the Mayo Clinic in Minnesota. Over to you.
Thank you, June. Thank you for having me. You've noticed I've already changed the talk. What I was given to talk about, can I see the title slide, please? What I was given to talk about was enabling hospital patients of the future, but I didn't like that very much. And what I really want to talk about is moving from practice need to innovation, and in the process, disrupting ourselves as providers and disrupting ourselves as patients and caregivers. So I come from the Mayo Clinic. It's a very large, successful hospital system in the United States. We work in 4 states, and we currently care for about 1.2 million patients actively. About 3.5 years ago, some extraordinary things started to happen in Rochester. And specifically, Mayo decided strategically that healthcare was going to be delivered and applied using mobile. And in late 2009, early 2010, Mayo implemented a mobile strategy which is changing everything. And it's vastly reducing complexity of care, and it's making things possible that were never possible before. I'm going to show you a specific application that was developed on our mobile platform. It's received a lot of attention. 10 days ago, it was featured in a webinar, The Evolution of Digital Patient Engagement Tools. And last week, it was picked up by the Harvard Business Review. This part is not important. I'm going to show you some screenshots of the application and what it does. but what's really important are the principles behind it. What you're going to see is that mobile devices are completely changing the way healthcare is delivered. It's going to turn you, I'm going to say later, from craftsmen priests into systems designers. And I'm going to show you how it's done. I'm going to talk about how mobile is the key to delivering care expectations to ourselves and to our patients. When we deliver expectations, all of a sudden there are levels of accountability that didn't exist before. If expectations are not clearly defined and communicated, there can be no accountability. And we have to have care that's good enough that when a patient comes into your office or hospital, we can say to them, this is the care that we will provide to you. So it's accountability for us, and we're also creating accountability for patients. Mobile is going to allow us to deliver knowledge in ways that have never been possible. And when knowledge is delivered, it changes the balance of power. It changes the way that patients and providers work together. Mobile also is going to provide us with data that we've never seen before. And what's going to come out of the combination of clear expectations and new data are new work models. And we're going to disrupt the psychosocial model of healthcare. And it's going to happen sooner or it's going to happen later, but it's going to happen. The origin of what we did resided in practice need. I helped lead a group that said, Mayo as an institution needs to figure out how to make hospital surgical care sustainable. We have to deliver it at lower cost and with higher quality. And what we found out when we looked at the surgical practice in a great institution is that communication, that there were poorly defined and poorly communicated care expectations. When care expectations are poorly defined, there is unwarranted variability. There was also huge disconnects between what providers expected and what patients expected. And that combination of things, that combination of things leads to overcare, too much care for too long, because things are ambiguous. And when there's overcare, there's lower quality and there's higher cost. Patient engagement is central to this. And so we make patient engagement part of what we're doing, and we built programs to develop patient engagement, not because it's philosophically appropriate, but because it's absolutely essential to patient care. Next. So what we did was we developed a template for surgical practice that said, this is the care that you can expect on each day of hospitalization. This is what's going to happen on day 1, on day 2, and day 3. And again, this is what patients want. They want to know what's going to happen to them each day. The other part of this creates accountability. What we wanted to do was tell patients that they can count on having a bladder catheter come out 2 days after surgery. What we wanted to do was provide patients with that information so when a cardiac surgeon or an orthopedic surgeon comes in the room, the wife or the spouse of that patient said, hey, my bladder catheter is coming out, right? Because that was the best quality care. And so we wanted patients to drive the process of care as much as we wanted clinicians to do it. So once we have a skeleton, a framework on which we can deliver care expectations to patients, all sorts of other things become possible. Next. So what we did was we built a mechanism to deliver a plan of care to patients by mobile. We told them what they can expect every day in blue. And once we know what they can expect, we can build all sorts of things on top of that skeleton. We can deliver to them tools that allow them to support their recovery, a domain called gaining strength. Once we have a framework, we can deliver in yellow modules for education. and we can deliver daily recovery planning. So we built customized care plans for patients, and when they came into the hospital, we gave them an iPad. And it provided an individualized plan of care with which they interacted. Next slide. The patient, it's secure. It's all the authentication is rigorous. When the patient logs on each day, they see a video that tells them what they can expect for the day. It tells them what they can expect from their providers. It tells them what they can expect from nursing, and it tells them what's expected of them. And this comes up automatically. Next slide. This is really the heart of what we're trying to do. Patients get a to-do list. Every day they get a to-do list. They're told what to expect, and they get tasks in gaining strength, and they get tasks in education, and they get tasks in recovery planning. Next slide. So what we did was we took vast amounts of patient education materials and parsed them into modules and created forms of education that could be delivered through iPads and consumed easily by patients. And so what we do is we're in the process of trying to deliver knowledge to patients. We're shifting the reservoir of knowledge significantly from providers to patients, because that's the only way new models of healthcare are delivered. And the education we deliver is just in time. Patients used to get a 285-page book and 2 DVDs and said, here's your education. What we now do is deliver education that's specific to them when they need it based on the care events of the day. Next slide. So that's education. In gaining strength, next slide, we turned provider tools into patient tools. So there's a provider tool that was used at Mayo for managing and supporting mobility recovery in geriatric patients. We turned that provider tool into a patient tool. So the iPad says, you need to get out of bed 4 times a day and walk 100 feet. We asked the patient, did you walk 100 feet 4 times? Please report it. Next click, please. The other thing we did, once we had a mobile platform, we put Fitbits on patients. I don't know if you know what Fitbit is. It's this device here. It's basically a fitness device. It's a mobility tracker. It's a wireless device that communicates through a PC and transmits how much time patients are out of bed and how much they walked. So we told patients how much they were expected to walk. We asked them how much they should walk, and we measured how much they should walk. We have new data that we've never had before. Next slide. The iPad communicates wirelessly through an antenna to the cloud. And that data populates a dashboard instantaneously. And what you see here is a dashboard. This is a bunch of patient names over here that are blacked out. Here you see a date, care plan day, and a bunch of alerts. So I can get onto my phone, I can look at a group of patients on a ward, and I can see how they're progressing in their care plan. I can see how much education is still pending. I get an alert, the lightning bolt, if their pain score is too high. I get an alert, the running man, if their mobility is too low. And I can get an alert if they're not getting out of bed. And all this is done through a mobile strategy. Next slide. We've also got data. We can look at a population of patients and therefore direct our attention where it needs to be right now. We also have individual patient data. On that same dashboard, if I click on an individual patient, I can see predictors of recovery. An ESDP score predicts, based on asking patient questions, whether they're going to need support going home. I can see where they are in completing their care plan. This is a representative patient. This one completed 100% of their care plan, which is why I show you this one. You can see their self-reported pain levels each day. This is self-reported data. It's probably more accurate than provider data. These 2 panels show how much the patients have walked, electronically measuring how much they walked. When we tried to look at mobility data, we found that the record was incomplete. It's not often documented. We don't know how far patients walk. If we want to accomplish one thing at the end of hospitalization, it's having patients sufficiently mobile to be able to care for themselves. That's one of the goals of healthcare. And we can see all this in real time. Next slide. This allowed us to create a new care model. So now we've got a whole bunch of patients, a new care model and a new work model that's directly integrated with data pouring off of it. So we've got patients A through F all working with an iPad with a plan of care. And they're self-reporting their pain, and they're self-reporting their mobility, and they're self-reporting their functional status. That's populating a dashboard, which we can see as providers, and we have algorithms then that send the right resources to the right patient earlier because their pain score is too high, or their mobility is too low, or the tool predicts they're going to need help going home. So this is a completely different work model, and I'll have you note, you don't see a physician in here anywhere. This is a work model based on real-time data reported by patients, managed centrally, and acted upon by non-physician providers. This is incredibly efficient. We published a couple of papers on the results. It shortens length of stay, it reduces cost. Patients are incredibly satisfied with it. Next slide. Mobile also allows new norms. We're going to get normative data that we've never had before. What you see here, this is a result from a paper we published in Annals of Thoracic Surgery. This is number of steps taken by day during recovery. We now have a good idea of what the normal trajectory of recovery is to recover normally and get out of the hospital in time. The upper curve of those who got home and the lower curve of those that don't. So mobile allows us to deliver care expectations. It allows us to deliver knowledge. It allows us to deliver self-assessment and reporting, and it's a platform for remote monitoring. Once we aggregate data, we end up with new care models, and we also disrupt ourselves. Next slide. I hope this doesn't offend the physicians in the room, but for 2,000 years, physicians have been like craftsmen priests. We operate in a guild that controls its own numbers. We learn through years of apprenticeship, and then we make judgments based on our unique intuitions and clinical experience. We're like priests in that we have a trust that's unparalleled, really, in social relationships, and we have an intimate knowledge that's completely almost sacred. But this model doesn't really work so well for chronic disease. The other side of this model is that patients are in the sick role. And the sick role is disease is something that happens to you and they're not responsible for it. That doesn't work for heart failure, and it doesn't work for diabetes, and it doesn't work for a whole variety of chronic conditions. We're going to move, like it or not, from being craftsmen priests to systems designers. That's what's going to happen over the course of the next 5 to 7 to 10 years. And the fluidity of data and the ability to design new care models with mobile technology are going to make radical changes in the way the care is delivered and the quality that's accomplished. Thank you.
Thank you, David. That was brilliant. What you're doing at Mayo is truly revolutionary and completely innovative. But do you think part of the reason that's possible is because Mayo is a streamlined clinic that's primarily private? So do you think it's easier to do within a system like yours?
It's easier because we're one location and one practice with central organization.
Yes.
And as I've talked to people here, it's become apparent that the NHS is administratively complex in ways that we're not.
Yeah.
But fundamentally, the things that we've done could be done at any one of the NHS sites.
Right.
The decisions are relatively simple ones.
Gotcha.
And the technology is relatively simple, and the costs are relatively low.
Right.
There just has to be a willingness to do it and to realize that we're going to significantly disrupt the way that we think about care delivery in ourselves.
You think that's possible?
Without question.
Without question.
And if you don't do it, somebody else is going to do it for
Somebody
you.
else is going to do it. You've got no choice. That's the way it's going.
Inevitably. And it's going to happen slower or faster. But by anticipating the changes, they can be shaped in the way that you want them to go.
Yes.
And you can create amazing value, an amazing experience that you don't get if someone else administers
It's just
that
it
for you.
Have there been other US clinics that have copied your model?
Not yet.
Not yet. So we're going to do it here first in the UK.
It's coming together piecemeal, but one of our strengths is the electronics infrastructure we developed. So in late 2009, 2010, Mayo made a decision, we are going to be a mobile institution. It made a decision that it was going to use the Apple iOS platform on which to develop applications. Once that was done, we could develop all sorts of provider tools and all sorts of patient tools and then bring them together in shared tools like the one I've shown you. But those strategic decisions are important ones.
Do you think also a system like this, primarily it's older people that tend to use the health system more? Do you think this sort of technologically advanced way of providing healthcare works better for young people?
Well, it certainly works
if
better.
If you're in your 70s or 80s, presumably you're not going to be on an iPad in the same way as a 16-year-old or a 21-year-old.
That's certainly true. In what we've done so far, our average age is 67 or 68.
Oh, wow.
And we asked all of our patients and subjects 2 questions. After a day or 2, were you comfortable using the program? And this is after they left the hospital.
Yep.
And second, did you use technology in your daily life? And we found that only half of the patients who participate use technology in their daily life. But overall, we had, depending on aspects of the program, 98% of all of the self-assessment tools were completed by patients, and 80% of all the education we threw at them. So if it's designed from the patient side, they can use it. And we designed this from social workers' input, and occupational therapists and physical therapists, and we sat in rooms with patients and said, what does this need to look like? And how would you use it? And we built it that way.
Right. Brilliant. Do we have any questions? Any questions? Mari. Rowena's coming to you.
Hi, my name is Mari Johnson. I'm from HealthBox. That looks like a really amazing application. And actually what I liked about it was the way that it incorporated so many different technologies, so many different themes that you see in terms of just the way it set expectations at the beginning, the accountability, the monitoring, the analytics. It incorporated so many different things, so really amazing. So I had two questions for you. One is, did you develop it completely on your own, or did you work with any other organizations, any startups or established technology companies? And the second thing is, are you going to maybe allow other organizations, maybe commercialize it and allow others to take advantage of the great application that you've developed? Because you could just see so many contexts where it would be relevant.
Be able to white label.
Yeah, so a couple of things. We built this for ourselves. And all of the design and all the functionality we designed and built ourselves. We had some contractors come in to support certain parts of the program. We're not real strong in some of the visual design, so we got some support that way. Our first priority is really significant scaling. So we built it first in the surgical practices. We're now looking at differing medical practices, and we've got a big proposal to Center for Medicaid Services, equivalent to your NHS, to push this program outside the hospital walls.
Right.
At some point in the future, if somebody wants to buy it or use it, that's a completely separate question. Right now, that's a distraction.
Answer your question, Mari? Any other questions? Gentleman here.
How have clinicians reacted to it in terms of their autonomy? Clinicians?
Oh, yeah.
Once again,
the clinicians,
how they received it?
Yeah.
I have to say that the response has been mixed.
Oh.
it solves a lot. We found that it solved a lot of problems that otherwise flew under the clinician's radar. So the average cardiac surgeon or vascular surgeon or chest surgeon may not even think about how much that patient walked.
Right.
Or they may not really have thought about whether the patient is meeting milestones for advancing diet. And they may not have thought about whether sufficient discharge planning has been done. What they saw was millions of dollars of savings that came out of shortened length of stay and remarkable improvements in patient satisfaction. But to be perfectly frank, the culture of medicine, and largely physicians are responsible, is they're really comfortable with patients in a dependent role and don't want to be asked by a 70-year-old woman, how come his Foley catheter's not out?
Yeah.
And so we are shifting significantly
The power balance.
to empower patients in ways, and it's requiring physicians and surgeons to think about different sorts of data, using it in different ways.
And so has it meant more work for the clinicians?
No, it reduces work.
It reduces
work because so much data is acquired and acted upon that they never even have to work with. I had one of the patients I met with after using the program was a physician and a hospital administrator. And every patient gets a set of survey tools that predict their likelihood of need for discharge support. And while the program was in testing, a discharge planner came to the room and started asking questions. And he interrupted her and said, my score is a 9. And she said, what? He said, my score is a 9. He'd already completed the survey. He was given the results. He was given the interpretation of the results before she even showed up. And he said to me afterwards, David, you could have saved the resource because she didn't need to come to my room, and that valuable resource could have been directed elsewhere where it was needed. And so it's designed really to improve workflow. It improves the patient experience, but it significantly impacts workflow.
Brilliant. We have time for a couple more questions. Any other questions? Nobody else, really? All of you technologically advanced people? Okay, well, I'll ask the final question then. So what is the future? Where do you want this to go?
The most important thing probably is building this out into the post-hospital and pre-hospital space.
Right.
Patients say, if you talk to them, I'm well supported in the hospital, but when I go home, it feels like the floor drops out. And so a large part of what we did was planning your recovery. And so we educated them about what complications are likely and risks.
So this is a program that you take home with you.
What we want to do next is build this program out from the hospital so it can be used for 60 or 90 or a year's worth of time.
Yeah, fantastic. Well, this is fascinating, and good luck with it all, and congratulations on this innovation.
Thank you very
David. Round of applause, everybody. Okay, so we have a short break, and then we will have the final and closing keynote of the day. I'm sure one that many of you are very much anticipating, with the Secretary of State, the Right Honourable Jeremy Hunt. So we will be back shortly. Thanks, everyone. Hello, everybody, and welcome to our final session. I'd like to introduce you to the lovely Sarah, who will be signing for this session. Now, they always say whenever you want to get to the root to know exactly what's going on. You need to follow the money. And our next speaker is definitely the person who holds the purse strings where the NHS is concerned. Glad you could all join us to hear from the Secretary of State. You'll also have a chance to ask him questions and have your say at the end of his speech. So will you please put your hands together for the Right Honourable Jeremy Hunt.
Thank you very much. Thank you. Thank you. Well, good afternoon, ladies and gentlemen. Thank you very much for staying to the bitter end. And as this is that was quite a good bit of signing for the bitter end. Actually, should we just have a round of applause for Sarah and also Dion, the signers, who've been working very, very hard. I really appreciate you inviting me to speak, and I think this is a fantastic conference. And I wanted to do something today that may slightly surprise you, because I think we've had a tough year in the NHS. But I wanted to explain to you this afternoon why I am fundamentally extremely optimistic. And when I think about my own job in the Cabinet, people often describe it as one of the more difficult jobs. I often say that I'm the only Cabinet Minister who no one else is jealous of their job. And despite that, I actually feel very optimistic. And there are three reasons, but one particularly relevant to Expo. The first is that we have had to deal with the incredible shock of mid-staffs. And I have been incredibly proud of the way the NHS has risen to that challenge and united really in absolute determination to make sure that we prevent that ever happening again. And I think that's been terrific. I think secondly, the NHS has also really started to understand the challenge of financial sustainability and some of the difficult decisions that we have to make in the way that services are organised. And that's been a very big change from 5 or 10 years ago. But the biggest reason why I am very optimistic about the NHS and indeed about the future provision of healthcare in this country is the reason that everyone is at Expo, which is that I believe that we have only barely scratched the surface of the technology revolution that is about to hit everything we do in healthcare, but particularly everything that happens inside the NHS. And I think it's just worth thinking about how little has changed so far in the NHS compared to how much has changed in so many other areas that we're all familiar with. So Christmas shopping, for example, 1 in 5 Christmas presents are bought online now every year. In fact, last year there was a 500% increase in the number of people who bought Christmas presents on tablets. That's a massive change. Now, if you look at banking, half of people do their banking online. That rises to 3/4 of under 35s. The retail banks have actually cut 1/3 of their costs by persuading us to do all the work that they used to do for themselves. And then travel, 70% of us now buy our air tickets online. We've had the whole revolution of the budget airline industry only made possible because of the way that technology can bring down costs. And you look at those changes and you think of what is possible in our NHS. And I think we are on the cusp of one of the most exciting changes in the delivery of healthcare that will ever happen in our lifetimes. And I think the biggest myth that technology can help us to bust is this idea that because of financial pressure, because of the aging population, because of these huge challenges we face, we inevitably have to accept that our care will become less personal and less high quality than we've been used to. Technology will help us do exactly the opposite. It will help make care more personal, more tailored, more in tune with our demands as an increasingly affluent and demanding population. And also, it will unleash through the data revolution some extraordinary scientific advances which will be of immense benefit, not just to people in this country, but to all humanity. And on which note, I just want to say a word about care.data. I actually want to say a word in praise of Tim Kelsey, who is over there, and I know has had a hard time in some of the Q&As that you've had here. And I just want to make this point about Tim. Tim did something very brave that no one in his position has ever done before. We've been using HES data for 25 years, and it's helped us to understand that there's no link between MMR and autism. It's helped us to understand the link between thalidomide and birth defects, between smoking and cancer. It's been incredibly important. But Tim was the first person who said, if we're going to go on using this data, and we're going to use it more than we've used it before, then we need to give people the right to opt their data out. And that is a very, very big and significant thing to say. And we are the first country in the world that is saying that. And as a result of, we're saying that because we want to take the public with us. The whole transparency revolution that everyone here believes in, otherwise you wouldn't be here. That is all about treating the public as our equals and telling them exactly what is happening with their data. And it's because of Tim's decision to give everyone that opt-out, the fact that we've publicized it by sending out leaflets, that we're having this debate. And I believe the result of this, although it's a painful process, will be much greater public awareness, much greater data security. I'm hoping to support that with, well, I will be supporting it with some big legislative changes that will give legal protection to any opt-outs that people do and legal safeguards on how the data is used. But I think that will be a very, very important step forward in terms of helping this country to develop some of the most exciting and far-reaching scientific advances in medicine as we have done over very many years. So anyway, I want to just return to this, this optimism. And I think one of the troubles with the technology agenda is that people can often sort of be futurologists and talk in a very excited way about things that are going to happen in 5 or 10 years. So I just want to talk about 5 things that will have a dramatic impact in the next 2 years. So just a 2-year period. And in fact, many of them will have a dramatic impact in the next year. And let's just look at these 5. So I've just got some slides. So here is the first. And this is about the availability, with your consent, of your electronic health record anywhere in the NHS that you need it to be. And that is going to be really, really significant. So some of the things that we often talk about in the healthcare debate, we talk about the integration agenda. But actually having a portable electronic health record is the backbone of integration. There can be no integration without proper technology sitting behind it. And by the end of this year, Tim has promised me that 1/3 of ambulance services will be able to access people's GP electronic health records. 1/3 of 111 centres will be able to access people's health records, so that if someone gives their consent when they're talking to a doctor or a nurse on 111, that person will be able to access their health record. And 1/3 of A&E departments will be able to access people's electronic health records, which will make a massive difference to people working incredibly hard under a great deal of pressure in A&E departments. But we should remember that last year, 44 people in the NHS died because they were given the wrong medicine. So to be able to see someone's medication or prescription history, to be able to see their allergies, has a dramatic impact on patient safety. And if you think about where this could lead to, for example, enhancing the role of pharmacies, some estimates are that 1 in 5 GP appointments could be dealt with at a pharmacy, but to do that, pharmacists need to be able to see people's records with their consent. And putting in place the right security, the right consents is a fantastically complicated thing to do, but that is going to happen, and that's all going to happen within the next 2 years, and that will be an absolutely huge change. It'll be something that happens in the UK and the US before anywhere else in the world, and I think will be hugely exciting. So that's the first change. Let me look at the next one. And this is someone who's not feeling very well, and it symbolises a very big move towards e-booking and e-consultations. So by next April, I do feel like a bit of a politician coming out with all these promises. They do say a promising young man should go into politics so he can go on promising for the rest of his life. So, and I'm very aware that quite a number of the things I've already said I can be held very accountable for because we have a general election in just over a year's time. But these are hardwired into the NHS system, and we are working night and day to deliver on these. So by next April, by the general election, 95% of NHS patients will be able to access their own health records online, will be able to book GP appointments online, and will be able to order repeat prescriptions online. And that will be something that will make a very big difference. If you look at the way organizations like Kaiser Permanente work in the US, there is there people are able to do their consultations by email, by phone, or by Skype. Some GPs are horrified at the prospect of their patients being able to email them. But actually, if you talk to GPs who actually do consultations by email, they actually wouldn't do it any other way. Because, for example, if you're a part-time GP, it means you can do your consultations from home without necessarily having to go into the surgery. And it allows a great deal of flexibility from the provision point of view as well as from the patient point of view. It's interesting, it's not just what's happening in the US. The Hurley Group are pioneering something very similar here, which I had a look at their demonstration on their stand as to what they're doing in the UK. And so we'll see a big move towards e-consultations and e-booking, and that too will make a big difference. So that's also going to happen in the next couple of years. And then the third big change. Now, we talk about the challenge of an aging population. And as I think everyone here will know, the biggest challenge with an aging population is the number of people with long-term or chronic conditions. 15 million people have a long-term condition in the UK, so around a quarter of the population. And we will see a very dramatic move towards people managing their own chronic conditions through apps. And this will be a very big and very significant thing. We know it has a dramatic impact, for example, for diabetes, 3.2 million people diagnosed with diabetes in the UK. And these apps can have a big, big impact in helping people monitor their glucose and insulin levels and help to avoid dangerous episodes. And it's not just for diabetes. I think there will be a big impact on the prevention agenda because these apps will also help people avoid developing long-term conditions as they get older. And in that respect, here in the UK, we have done something very exciting, which is we've signed an accord with the US, which creates a single market in apps. So I signed an accord last month with the US Health Secretary, which means that any app that's approved for use in the NHS, it's able to quiz medical records and so on, will automatically be approved for use in the UK, and anything that's approved in the UK will automatically be approved for use in the US. And that, I think, will be very exciting for developers in the UK, because it will mean that if they can get something approved here, the whole of the US is open to them as a market as well. So use of apps is something that will be a very big change, and I think NHS Choices already has 160 apps, is it, Tim? It's 160 apps already approved, and it's growing the whole time. So that's going to be a very big change. Let's look at the next thing that is going to have a very big impact is the way that we are going to use data to drive up quality. Now, the NHS has already been a world leader in the way that we have done this using heart surgery under the leadership of Ben Bridgewater at Wythenshawe Hospital and Bruce Keogh, heart surgeons who persuaded their colleagues to publish heart surgery outcome data several years ago, as a result of which we moved from being one of the worst performers in terms of heart surgery outcomes in Europe to one of the best. And the interesting thing is, so for many years now, you've been able to actually look at the performance of individual heart surgeons online. But even if you don't, they look at that data and they use it to improve their performance. So if you look at, for example, comparative GP data, if you look at data on emergency admissions for people prone to risk of falling, in the CCG, which has the worst record in the country, I won't say which it is, they have about 186 emergency admissions per 1,000 patients who are prone to falling. The CCG with the best record in the country, which is actually Salford, they have just 5 emergency admissions. So the difference is between 186 emergency admissions and 5 emergency admissions. And comparing this clinical data is a fantastic way to improve outcomes. And if I just show you with dementia, we have something very similar happening where we're trying to reduce the time it takes to go through the process of getting a dementia diagnosis. And in the least well-performing parts of the country, it takes nearly 6 months to get a dementia diagnosis. In Staffordshire, which is one of the best, it takes 4 weeks. And this data can have a huge impact on improving performance. And I just want to say why I'm not jealous of any of my colleagues in the cabinet, because this is something that is uniquely happening in health. I mean, let's just think about education reform. There's a lot of discussion about education reform. Do we have any data that actually compares the performance of individual history teachers in 24,000 schools up and down the country? Basically, we don't. And it's very difficult. You have the exam results, but the actual data, risk-weighted, based, taking account of the abilities of the child, we don't have that performance. We are now going to be in a position where we can use that information. Do we have any information that can compare the performance of individual police officers investigating murders in every part of the country? We don't have that data. In health, we do, and we can use it to drive up standards. And because we are so in the lead in the NHS in this, I think we can use it to drive up standards so that we are quite simply the highest standard and the safest care offered anywhere in the world. And that's what our commitment is to do. So that's the fourth area where I think we're going to see a huge change. And then the final area is not Jeremy Hunt. I'm hoping he'll stay. But it's not. The final area is actually something I've got in my pocket. So on this chip that I've got here is almost an entire human genome. And this is another absolutely extraordinary advance that we're going to hear a lot more of in the next few years. So this is actually the genome of someone who has breast cancer. Obviously, they have consented to have their genome mapped. And we want the UK to be the first country in the world to map 100,000 whole genomes. And we believe this will give us a huge treasure trove of information, particularly about rare diseases and rarer cancers. And this is going to have a huge impact. Just to give you an idea of the complexity of this, if you asked someone to type out a whole genome, working at 60 words a minute for 8 hours a day, it would take them 50 years to type out one genome. And if you unraveled human DNA, it would actually stretch up to the moon and back 6,000 times. So this is an immensely complex area. And this is why the care.data debate is so important. With the consent and trust of the public, to be able to map the information on a genome onto someone's medical history will give us a huge, huge amount of information that will save thousands and thousands of lives. And that too is a massive and very exciting change. So with all that to look forward to, I would actually put the argument the other way. What is there not to be optimistic about? I think there is a huge amount on our doorstep. I think that's why Expo is so successful because people recognise that. I think taking it forward, we need to show humility. We've had plenty of IT catastrophes in the NHS before, and we need to make sure we learn from those mistakes. We need to show patience, because it isn't all going to happen at once, and there's a lot of detailed implementation and execution work, and there's a complex balance between initiatives from the centre and also nurturing the ideas and innovation and genius of developers on the ground. But most of all, we need to have confidence, because this is something that really can be totally transformative for our NHS. And we need to recognise, I think Shakespeare said that our destiny is not to hold in the stars, but in our own hands. And that is what is happening with the whole technology revolution in the NHS. So I can do some of this. I've said that I want the NHS to be paperless by 2018, and I think we're making good progress. NHS England can do a great deal of important work as well, but actually all of us have to really make sure that we deliver on this, and all of us have to carry the public with us. And if we do that, I think there is an incredibly exciting future for healthcare delivery in our country. Thank you very much.
Secretary of State, thank you very much. Can I call you Jeremy?
Please do.
No? Jeremy. I won't ask too many questions because I'm sure there are many people in the audience who would like to have their say. But I wanted to get your opinion on one of the things that came up earlier in our conversation regarding care.data. Actually, Tim, you didn't get as hard a time as you thought you were going to get, did you, in that session? Yesterday. Was really that actually one of the key problems is the fact that our data doesn't belong to us. It effectively belongs to you. Are you going to do anything around that part of the legislation?
Well, I believe our data does belong to us. And I think it's very important that, we make it clear to the public that it is their decision how their data is used. And that's why one of the things that we announced on Saturday is a change to the care bill, which will mean that any patient that wants to opt out of care.data, at the moment we've said that we will respect that, but actually we're going to put it in legislation so that we will be legally obliged to respect that decision to opt out. Right. So I think de facto what we're saying in that is that actually patients have the right to decide how their data is used.
Okay, well, let's open it up to the floor. Any questions? Wow. Okay, we're going to go to this man there first. Yes, you. If you could tell us your name and where you're from.
Hi, my name's Alistair Stoddart. I'm from the Democratic Society, and it's great to be here. Jeremy, there's a lot of knowledge in this room, we can all attest to that, about how we can make the NHS more patient-centred and responsive. But what will you do as Secretary of State to help us achieve a more responsive and patient-centred NHS?
Well, I think we have to, I'm just going to stick with the technology theme for the moment, Alistair, but I think the point about technology, the big change in technology is that if we get this right, we can put people in the driving seat of their own care. And I think, we've got to move away from the paternalistic model of care, where your care is administered to you by people who know better than you. We had, a slide about diabetics. What a lot of diabetics will say is that the frustration they feel is that sometimes they're talking to GPs when they feel they know more about diabetes than their GP. Now, that's not true of many GPs, but I think we have to recognise that we need expert patients. We need people to be in the driving seat. Technology can really help people do that, and if we get this right, we can also bring down costs for the NHS as well.
The gentleman there was in the red was next. You with the T-shirt. And then there was somebody around here as well. And then we'll
Martin Rathfelder from the Socialist Health Association. When you say that patient records belong to them, does that mean they're allowed to look at them?
Yes.
Well, I wasn't.
Well, I agree with you that it is a big, it is very odd that there are still parts of the NHS where you're asked to pay £20 if you want to access your
That's
record.
what the official guidance still says, that
Well,
I can only see my records if I submit an application under the Medical Records Act.
Well,
and I have to wait 6 months.
Well, the good Mr. Kelsey over there, who's actually standing next to the chair of NHS England, Sir Malcolm Grant, has sworn in blood that by next April, 95% of NHS patients will be able to access their own records online. And there's no intention to charge, there's going to be no fees at all. This is going to be something as long as you're able to identify yourself. So I hope we will crack that problem.
Okay, there was a question. It was you and then you. No, you, then this lady here. So, gentleman just there.
My name is Derek Whitehead, and I'm speaking from a rather peculiar position in that I'm very impressed by this data extraction system which you described, because I happen to be so old that I actually pulled to bits the world's first programmable digital electronic computer, on which I happen to also know Alan Turing. So you do realise that I have an infinite age. One of the things that comes from that infinite age is that when I was young, Alzheimer's disease virtually was non-existent. Unfortunately, it has become a problem of success, because in the years since I was young, the average lifespan has increased by probably more than 20 years. And that is unfortunately a gate into which the Alzheimer's disease has crept. The question I want to ask you is, really, there will always be such a problem, even if we live to be 120. But what can you and Alistair Burns do about Alzheimer's disease, as it is now fairly well understood that it, at least in part, is triggered by the presence of the herpes simplex type 1 virus? So I'm really asking a question. A, I'm wonderfully impressed by your data processing systems, but please do look at the problems of success.
Well, I agree with you, and I think actually dementia, and more broadly, is a litmus test of whether we tackle the challenge of an ageing society for exactly the reason you said. We'll probably have 1 million people who have dementia, the majority of which will have Alzheimer's by 2020, which is a huge number of people. And the most shocking thing of all at the moment is that we diagnose less than half of them. And so there's less than half of the people who have dementia who could be helped by medicines, which have some impact for about 1 in 3 people, who could be given care plans that could help them live for longer at home without having to go into residential care so soon. All that help we could be giving, and we're not giving, and we would probably be saving the NHS money if we were giving it as well. We need to do a lot better in terms of the identification and the support we give to people with Alzheimer's and dementia. But I think on the research side, the most important thing is not to lose hope, because actually there are some very exciting developments. I was in Paris last week talking at the leading dementia research facility in Paris. And there are scientists there, and there are some in London as well, who think that by as soon as 2020 there could be drugs on the market that actually could halt the disease in its tracks. And I think it's worth remembering how helpless we all felt in the face of HIV/AIDS in the 1980s, and the extraordinary progress we've made with antiretroviral drugs in enabling people to have normal life expectancies. And so I agree with you, there'll always be another disease that we catch as we have longer life expectancies, but I don't think we should be defeatist about Alzheimer's.
Hello, my name's Charlotte Peters-Rock. I am a carer for 3 people, but also I hold a registered power of attorney for health and welfare for 2 of them, both of which have been lost, one from hospital records and one from GP records. And as we're all aware, this is a legal requirement. It's a legal document which should be safeguarded. And I give you that as a concern in respect of the care.data. The other thing I wanted to raise with you is the fact that dementia is a health problem. It isn't a social care problem. It can only be warranted by someone within the NHS, effectively a GP or a consultant. And also, as a family carer, I feel that while the talk is being given about all the help we get, the problems we're having are that we again are pushed into the social care system for our own respite. We're constantly told to keep your health good, you need adequate respite, you need to take time to do your own things as well as looking after people. I've been run around looking after 3 people now for years, and it is something I'm more than prepared to do, but I see no reason why the NHS should push me into social care for health respite.
Well, the first point you made about data security is very, very important. And I think the examples you gave of records being mislaid or lost are things which I think probably happened before there was any discussion about care.data. Yes. And one of the things that is happening with the new Health and Social Care Information Centre, which is a new body that's been set up from April of last year, is that they have much, much more robust and secure systems in place than the NHS has had previously, and much stricter protocols about the way data is released. So I hope we will be able to avoid some of those kinds of problems. But I don't want to pretend it's going to be easy, and there's going to be a very big learning process as we get through it. I think most people I talk to who are caring for people with dementia would say that it's a health and a social care issue, and that we need to be better on both fronts. But I think the point you're making, if I understand it, is that we need to give support to carers, but it needs to be tailored support, the kind of support that will help them, and it'll be a different type of support for different types of people. Some people who perhaps have a husband or wife or a partner of many years who have dementia don't get as much support as they should. And the pressure gets greater and greater and greater, and then finally they snap, and their partner is taken into residential care because they can't cope anymore. And what I think we should be better at is giving people support along the way, so that that doesn't happen until a later stage, because everyone would prefer to stay at home for as long as they could. Maybe it doesn't have to happen at all. And that's where I think we could do a lot better.
What sort of support would you want to see come into action? Because for you, it's as a family member, isn't it?
Well, for me, it's as a woman of 68 who has been made utterly exhausted by the system, and particularly by, even though it's a legal requirement, the total lack of corporate accountability. Is that something you can tighten up if you're changing laws?
Well, I think we are definitely wanting to change the accountability throughout the whole system. So that's why we've got the new chief inspectors of hospitals, of social care and of general practice. But I think there's a specific accountability which you're talking about, which is to know where the buck stops in the NHS.
Yes. And no
for
covering
the
up.
care of the person that you are looking after.
Yes.
And that's something where from April this year we'll have named GPs for all over 75s. That'll be a big first step. I'd like to take that further, but that will help a lot of people with dementia. But I think when it comes to out-of-hospital care, we need to be much, much clearer about where the accountability lines are.
And people must talk. Thank you very much.
Lady over there.
Thank you. My name is Julia Simon. I work for NHS England in Commissioning Development. We have heard a lot in the last couple of days about the kinds of changes that need to happen in the NHS if it is to survive, both financially but also with a focus on patients and quality of outcomes. And we know, as David Nicholson said in his speech earlier, his interview, how much has to change in terms of healthcare delivery and how much noise that tends to cause. So in about 4 weeks, we have a new chief exec, Simon Stevens, coming in, and he's got a really formidable task to drive through a lot of this with his organisation. We're also coming up to a new general election. Could you say something about how you personally will support the changes that need to take place in the NHS and how you will give political cover for what has to happen if the NHS will survive?
Well, I think I have taken pretty much every difficult decision that's landed on my desk. And you know, if I think of the decision last week on mid-staffs, which is a very difficult decision, if I think about the decision in North West London, the decision in Trafford, I took a difficult decision in South London, but had some difficulties with the High Court. But you know, I don't think there's been any lack of willingness to take those difficult decisions on my part. But what I'd say is that I think the public find those decisions far more palatable if they are not driven from the centre by people like me, but actually driven locally and driven by doctors. And I think what we've learned in the last couple of years is that actually there is a way that you can persuade people to accept really quite complex and difficult reconfigurations. I mean, North West London was a good example because it was closing 2 A&Es and downgrading 2 other A&Es, but it was argued passionately by local doctors. And also, at the same time as arguing the case, they argued the positive benefits to the public. So 7-day opening of GP surgeries, 7-day working of hospitals, 3 brand new elective hospitals. Some really positive messages went out as well, which is why I think that decision landed pretty well. But I think that the mood has changed. I appreciate that there's a lot more to do, but I think that throughout the NHS there's an understanding of the need for change, and I think the public understand the need for change as well. It's just that we have to make sure that we make the argument in terms of improving quality and not simply about an argument about cost cutting or money.
Thank you. My name is Caroline Day. I work for a provider group called One Medical based in Leeds. You mentioned, Jeremy, that moving forward we need humility and that we've made mistakes. We must demonstrate that we've learnt from them to move forward. How can you reassure the public that the new innovations that we invest in are well evaluated and that it's a good use of public funding?
Well, I think it's a very, very good question. And, you know, when I gave a speech just over a year ago saying that I wanted the NHS to be paperless by 2018, I think it's what Sir Humphrey would have called a brave thing to say, because, you know, we've had our fingers burnt in the NHS in the past. But I think the biggest thing that we've all learnt is that top-down does not work as well as bottom-up. And so what you can do from the top is give a sense of direction, but what we need to do is to make sure these are locally owned projects, locally nurtured, and there's a sense of local commitment. I think what happened before with Connecting for Health was it became the kind of the NHS's equivalent of an aircraft carrier, an absolutely huge project that got bigger and bigger as the years went on and eventually became completely unmanageable. And we were trying to specify absolutely everything from the centre, and I think we've learned that isn't the way to do it, and that's why I think we're making much more progress doing it this way.
Thank you. My name is Evelyn Bitcon, and amongst other things, I am a carer, and I'm also an advocate for the public. And in another life, I'm actually chair of the National Carers Forum at the Royal College of Psychiatrists. It does concern me and many others, though, that I'm very impressed with what I've seen here over these 2 days. But people are human beings. And what we must never, ever get away from is how we actually respect and value them. It's very simple, a very simple message. And when you look at parity of esteem, the link between physical health, mental health, and well-being, especially around long-term conditions, we're missing a valuable asset that could actually save the country money, would actually have a lot of less people in the NHS off sick, and I used to work there. And we're missing the point of looking at the whole person. And what I'd really like is your reassurance that we won't lose sight of parity of esteem, that it will actually, because it seems to have gone very quiet.
You absolutely have that reassurance. I mean, this is the government that legislated for parity of esteem between mental and physical health in the 2012 Act for the first time. Norman Lamb and myself are absolutely passionate about making sure that we make significant progress. We've committed to introducing a waiting times target for mental health before the end of this Parliament. So we are absolutely committed. I think it's a very important point you make, if I may say, because technology is very exciting for those of us that are turned on by it, but it is a means to an end. It's a means to delivering more personal, more human, more safe, more compassionate care. And so, you know, what technology should mean is that if you dial 111 because you're feeling a bit poorly, if you consent to it, you can talk to someone who can look at your medical record and you can feel they know you and they can give you good advice rather than talking to someone who doesn't know you from Adam. So it should mean that you can deliver much more personal care with that human touch. But I think it's really important that we always understand it as a means to an end and not the end in itself.
So you are giving me some hope to take away then that we will experience this on the shop floor, please?
Well, if we don't experience it on the shop floor, then we're all wasting our time, because that has to be the point of it all.
Thank you. Yes, lady there. And then we'll do a final question, which will be you after Dr. Jim.
Thank you. My name's Tanya Sahid. I'm a pharmacy student, but I also work with NHS 111 as a call operator. Just to buttress what the point that the lady said, you mentioned about top-down not working as efficiently as bottom-up, and being somebody who works at the very bottom at NHS 111, these innovations and all of this move towards better patient care, and as a future professional, how these have to be driven by humans as well. So what's the assurance that we're going to get the support that we need to do our job, and it's not just going to be about more red tape and meeting the targets? How do we know that we're going to have the proper support to do our jobs efficiently?
And to use these new innovations.
Yeah.
Look, I think 111 has a very, very important role. It is meeting its operational targets, and perhaps because of some of the publicity when it was launched, the public aren't aware of that. But I think that we could do a great deal more to support you by, as I mentioned actually earlier, by allowing, with patients' permission, 111 operators to access medical records so that you know more about the person that you're speaking to. I've always wondered whether we could do a lot of work on the algorithm that you have to use to make it shorter and simpler and allow 111 operators to use more of their judgment. So I think there is a lot we can do, but it is absolutely the contact that you have with the public, the contact that a GP has, the contact that a receptionist in an A&E department have. You know, they are what the NHS is about. That is the interface that people have, and it's really important that we support the people doing those roles so that it can be as welcoming as possible to people who are in distress.
Okay, well, Jeremy, you have to go, don't you? So we don't have time for any more questions.
I'm afraid not.
Dr. Jim, I'm so sorry, we missed your question. Well, thank you very much for joining us. Fantastic conversation, and thank you all for spending the past 2 days with us here at the Expo. Hope you all get home safely, and yeah, good luck with everything for the coming year and all of these new innovations you'll be using. Jeremy Hunt, everyone.
Thank you.